Good afternoon, buenas tardes. Thank you to the organizers for inviting me to participate in this exciting debate session. These are my disclosures, and along with my debate teammate, we will be arguing for the proposition women living with HIV should receive statin preventive therapy to reduce cardiovascular risks. So argument number one, women living with HIV have increased risk of cardiovascular disease compared to those without HIV, and also relative to men with HIV. So there are multiple cohort studies that have shown that the risk of myocardial infarction and strokes is about 1.5 to 2-fold higher in people living with HIV compared to persons without HIV. But even among people with HIV, studies from multiple cohorts have shown that women with HIV have an elevated risk of cardiovascular disease compared to age-matched men with HIV. This was first reported in multiple analyses stratified by sex within large North American and European cohorts. I show you here in data from Jeannie Triant's study that the relative risk of women with HIV versus women without HIV almost reaches 3, while the relative risk for men with HIV versus men without HIV is only about 1.4. Data from France similarly showed that both the absolute and relative risk of MI were higher in women with HIV than in men with HIV. Also, both men and women with HIV have an earlier age of onset of MI compared to people without HIV, but the age of first MI for women is about 6.2 years earlier compared to about 2.1 years earlier for men with HIV. So these data, estimating sex-based adjusted relative risk for CVD, have been verified in more recent studies, including some in sub-Saharan Africa. A similar sex difference is also seen in strokes, as shown by the data from the ACTG. So this problem of increased relative risk of women compared to men is confounded by the fact that cardiovascular risk calculators underestimate the risk in women with HIV, as I'll show you next. So in a recent publication from our Reprieve trial group, the pooled cohort equation and the DAD risk calculators underestimated CVD risk in women and Black people with HIV in high-income countries. How off are these estimates? To obtain a more accurate risk estimate, you can't just assign women with HIV the same risk as men. The pooled cohort equation, for the pooled cohort equation, you would have to multiply it by a factor of 2.8 for Black women and 2.6 for women who are not Black to get a more accurate assessment of risk. So why is this important and concerning? Because several studies have reported that women's perception of their own risk tends to be lower than men's. This is further reinforced by their own providers, who also may incorrectly perceive a woman's risk to be lower than it is. This, of course, could result in less attention paid to modification of traditional risk factors and possibly delayed diagnosis of MIs and strokes in women with HIV. So, argument number 2 is women living with HIV have an increased risk markers of inflammation and immune activation, which are amenable to be targeted by the anti-inflammatory pleiotropic effects of statins. So chronic inflammation and persistent immune activation is likely to be a key underlying mechanism explaining the excess risk of HIV-associated cardiovascular disease. And the reason why the relative cardiovascular disease risk in women with HIV is higher compared to men is due to women with HIV having a more robust innate immune response to HIV infection. So several studies in North America and also in sub-Saharan Africa have shown that women with HIV have the highest levels of markers of immune activation, such as soluble CD14 and CD163, compared both to women without HIV, but also compared to men with HIV. And indeed, this is also shown in the Reprieve trial data, where we can see multiple immune activation inflammatory markers increase relative to men in the study. So how does this relate to statins? We already know that statins lower LDL cholesterol, but they have additional pleiotropic effects, including anti-inflammatory effects, anti-thrombotic effects, and other benefits. This was, in fact, the basis for the Reprieve trial. Statins have been shown to specifically reduce markers of inflammation and immune activation in people with HIV. These data by Nick Vanderberg show significant reductions in multiple markers of inflammation and immune activation in participants randomized to take rosuvastatin compared to those assigned to placebo in the Statin HIV trial. So this takes me to my third argument, and that is that statins are very effective at reducing cardiovascular disease risk in women living with HIV. So let me talk briefly about Reprieve. The study enrolled people living with HIV on stable ART between the ages of 40 and 75 without cardiovascular disease or other indications for statins. The study enrolled 7,769 participants in 12 countries. The study was double-blind, and participants were randomized 1-to-1 to take pitavastatin 4 milligrams or placebo daily. The primary endpoint was major adverse cardiovascular events, that are shown here. Clinical events were adjudicated by an independent committee. So the study enrolled 31% women. Notice that the median ASCVD risk calculated by the pooled cohorts equation was 4.5. Here, we see a comparison of baseline characteristics of men and women, and we can see that they're very similar, except for the fact that the median ASCVD risk score for women was only 1.9, whereas for men it was 5.4. The study was stopped early due to efficacy. After a median of 5.1 years of follow-up, the reduction in incidence of first MACE was about 36%. And most importantly, we see that the treatment effect for women was the same as for men in the study. We can actually calculate how much reduction in cardiovascular events to expect based on LDL reduction. Based on the reduction in LDL observed, we would have expected a reduction in MACE events of about 17%. But what we found was actually 2 times that expected effect. This suggests that the pleiotropic effect of the statin played an important role in reducing risk beyond that expected by lipid lowering alone. Sorry, this was actually what I was showing. So this has led to changes in the guidelines, treatment guidelines, both in the US, in the UK, and in Europe. And in the US, statins are recommended for all people with HIV ages 40 to 75. Notice that for those without ASCVD risk calculated as higher as 5% or higher, the recommendation is an A1 level with the highest level of evidence, whereas for those with an estimated risk of less than 5%, the recommendation is C1 with a lower level of evidence. We believe that based on what I just showed, about the underestimation of risk for women with HIV by the pooled cohort equation, the recommendation should be an A grade for all women with calculated risk less than 5%. So, statins for primary CVD prevention in people with HIV are safe. So the Data Safety Monitoring Board concluded that there were no unanticipated safety concerns. Also, serious adverse event incidence was low in each arm. Myalgias were higher in the pitavastatin group, but were mostly mild, and less than 1% withdrew for muscle-related symptoms. Also, there were no grade 3 ALT elevations and rhabdomyolysis related to the statin. Diabetes incidence was modestly increased in the pitavastatin group compared to placebo. This was consistent with other statin studies. And in this analysis that we published last year, we see that there was a small cohort that actually had diabetes incidence, and they mostly had multiple risk factors for diabetes. So.